Okay, we're going to start talking about positive pressure ventilation. So far we've talked about negative pressure ventilation, and we've somewhat talked about positive pressure ventilation. Whenever you push air into the lungs, that's positive pressure ventilation. So whenever you are bagging your patient, you are using positive pressure ventilation. When we were working with the compliance and the raw exercises, you were using positive pressure ventilation. What you didn't know is that you were using pressure and volume ventilation, because those are things that I was doing for you and you didn't know what buttons I was pushing. So whenever we look at positive pressure ventilation, there are some subcategories under that. The first one is pressure. What that means is that you can actually set a pressure to fill the lungs. Normal pressure is probably about 20 centimeters of water pressure, depending upon the patient. So you can set a machine pressure to 20 centimeters of water pressure, and for every breath, the lungs are going to get 20 centimeters of water pressure because that's what you have it set. Or you could use volume ventilation, and with that you're going to set a certain volume. For example, you'll use your ideal body weight. For me, I would be probably 54 kilograms, and so because of that you would have a tidal volume of about 350. So you would turn the volume knob on your ventilator to 350 mLs, and then every single breath I got would be 350 mLs of air. So you can either set the pressure or you could set the volume. Then we also have transport ventilators and home ventilators. Transport ventilators are ones that are used in the hospital. For example, if you have a patient who is in the ICU on an event and you need to go to MRI, we have a transport ventilator because not all ventilators can go to MRI. We also have home ventilators that are different from those in the hospital. For example, they're not going to be pneumatically powered, they're going to be electronic or battery powered. So there's just some subcategories. You've got negative pressure ventilation, positive pressure ventilation, and then under positive pressure ventilation, you've got these other subcategories. We've already talked a little bit about minute ventilation. You guys know that in order to get minute ventilation, you take the tidal volume times the respiratory rate. The reason why we worry about minute ventilation is because it controls our CO2. You guys are talking about ABGs and CO2 and too much CO2, hypercarbia, not enough CO2, hypocarbia. But what affects that is essentially minute ventilation, the size of the breath and how many times they take that breath. For example, let's say that for some reason you're just panting. You're taking really small breaths, but your respiratory rate is fast. You're going to have a certain minute ventilation. However, if you take a bigger tidal volume, you can still have the same minute ventilation because you've taken a bigger tidal volume, but you've slowed down your respiratory rate. So your job as a respiratory therapist is to find the best minute ventilation using tidal volume and respiratory rate so that the patient is comfortable and the CO2 is perfect. And we're going to teach you how to do that. So you can do that by either increasing the pressure or increasing the volume. For example, I just happen to have a baby and a bag on my desk, because who wouldn't have that on their desk? We kind of did this in class a little bit. So if I want to increase my minute ventilation, I can go from a tidal volume like this to a tidal volume like this. I'm using a bigger tidal volume. I'm going to blow off more CO2. Or I can increase the rate by using the same tidal volume, increasing the rate. Again, I'm going to blow off more CO2. If you have any questions on that, we'll talk about it in class. I know we haven't talked about indications for ventilation, so we'll talk about it real quick here. What's listed on this slide is minute ventilation. If somebody is not ventilating, they need a ventilator. Somebody who's not ventilating may be apneic, they're not breathing at all, or they may not be ventilating enough. For example, their CO2 is too high. So if somebody's minute ventilation is not high enough, they're going to need a mechanical ventilator. That is, if they're not ventilating, they need a ventilator. If somebody's CO2 is greater than 45, we say they're hypercarbic, and their pH is less than 7.35, we say they're acidotic. So if we have a patient whose CO2 is high because they're not breathing, we're going to say their minute ventilation needs to be improved by putting them on a mechanical ventilator. So if a patient is apneic, not breathing, or they're not breathing enough, meaning their minute ventilation is not high enough, we're going to have to put them on a ventilator. I know that you are talking about ABGs and FRC2, and you're just now learning, is it normal, is it compensated, is it uncompensated, is it respiratory, is it metabolic, and I understand that, and all of that is important to know. However, for this class, I'm going to take kind of a different avenue. I still want you to know, is it compensated, is it fixed, is it partially compensated, is the body still trying to fix it, or is it uncompensated? It's so acute that the body hasn't even tried to fix it yet. Those things are important to know, but we look at things in a different way for ventilation. The letters to remember are V, O, C, U. And the first question you ask yourself when you get your ABG is this: are they ventilating? Is their CO2 35 to 45? If it's greater than 35 to 45, they're not ventilating well enough, and they might need a ventilator. Then you ask yourself, are they oxygenating? Is their PaO2 80 to 100? If it's less than that, they're not oxygenating, and they might need a ventilator. Now we'll get into some more specifics later on, but I just want to kind of get you into the habit. Go ahead and in Jennifer's class, absolutely do the partially compensated, compensated, respiratory, metabolic, whatever it is, but also be thinking, are they ventilating and are they oxygenating? And if you can start doing that as we continue through the semester and as you learn mechanical ventilation, and when you go out to clinicals, you'll find that keeping in mind the VOCU, are they ventilating, are they oxygenating, are they circulating, and what is the underlying problem, keeping those letters in mind will help you. Some students call it VOCU, it helps them to remember. Ventilating, oxygenating, circulating, and then what is the underlying problem. This slide talks about positive pressure ventilation and what it does to the interpleural space. You've seen a picture that looks somewhat like this when we were talking about negative pressure ventilation and spontaneous ventilation. But this is what it looks like with positive pressure ventilation. I want you to notice that the interpleural space actually becomes positive. This is completely opposite of how it's supposed to be. We don't walk around pushing air into people's lungs. We've talked about that before. However, whenever they're sick and in the hospital, that's precisely what we're doing. And because of that, there are some side effects that we're going to talk about on the next slide. Because positive pressure is not normal, we can have side effects from that, as we talked about on the previous slide. There are different ways to provide the positive pressure ventilation. I know in that first slide we talked about volume or pressure, and that's ways that we deliver that tidal breath. Is it a volume control breath? Do we just set the volume and that's what we're worried about? Or is it pressure control breath where we just set a pressure and that's what we're worried about? And then we also talked about the home ventilators or the transport ventilators. I'm going to add to that, sorry. But we have invasive and non-invasive. Non-invasive ventilation is with a mask. If you guys know anybody who maybe has sleep apnea, and they have a CPAP machine at home, that's non-invasive. We're pushing air into the lungs non-invasively, meaning we're not going inside the body. The pressure is delivered with a mask. It goes around the mouth and the nose, somewhat like the mask that you use when you're bagging somebody, and they use that to help them sleep better. We also do that in the hospital for other reasons, so that's non-invasive. Then we have invasive, in which the endotracheal tube goes into the body, outside the body to inside the body. That's invasive. So that's invasive positive pressure ventilation. Side effects from either invasive or non-invasive, we're going to put those together for this slide, would be increased intracranial pressure. So we can measure the pressure inside the head. Don't do it very often, but we can. And the normal is about 20 centimeters of water pressure. Anytime you're going to mess with the heart, you're going to mess with the intracranial pressure because you're going to be changing the blood pressure. So like we were talking about in class the other day, if you inflate the lungs and you kind of squash the heart, that heart can't fill up with blood as much because there's not room to expand. So it's not going to be as full as blood, which means that blood's going to be pooling even up here, increased intracranial pressure because the blood is just sitting in the vessels up here. Then hypotension. Hypotension means low blood pressure. Hypo, low blood pressure. And again, that's because we're squashing the heart. So if the heart can't expand as much, it's not going to pump as much blood, and blood pressure could potentially fall. Another hazard of positive pressure ventilation is barotrauma. Baro means pressure, like barometric pressure, barotrauma. It's trauma from pressure. If you set the pressure on your ventilator so high that the alveoli expand, they could actually get holes in them and shred. And you guys have probably been around somebody who has blown up a balloon and they were pushing so hard that the balloon exploded. That's kind of like barotrauma in the alveoli. So we have barotrauma, and then we also have volutrauma, which means too much volume in the alveoli, which is why figuring that ideal body weight and using the appropriate tidal volume is so important. Because if you don't set the right tidal volume, you could actually cause volume trauma. So here we are trying to help the patient, help their lungs, and we do things like barotrauma and volume trauma, causing injury to the lungs that we're trying to help. And so that's why we have to pay attention to those plateau pressure numbers, those static compliance numbers, and have to make sure that tidal volume is set correctly. And then the last thing, because we're going outside the body to inside the body with the endotracheal tube, infection is going to be a huge concern. And we look at VAP. That stands for ventilator-associated pneumonia. Anytime you put somebody on a ventilator, there's a risk of pneumonia. In my opinion, it should be called endotracheal tube-associated pneumonia because that's what's really causing the injury. But again, we're going from outside the body to inside the body, and we're constantly handling that ET tube. We're suctioning the patient, we're doing oral care, we're moving the patient, we're turning them, we're always touching that ET tube to make sure it's in the right place, and that's all a risk for infection with all that handling.